Well, welcome everybody. This is the first webinar of the GSPP in the spring semester. We are very happy to have a chance to start off with a presentation by Ramesh. Ramesh has been a great friend of me personally and of GSPP in general, because many of the programs and the courses we teach here are courses that he designed, co-designed, and taught us how to teach. So we are most grateful to him for historical reasons, and we're very grateful for him for accepting our invitation to come here and make a presentation today. For those who don't know Ramesh is a UNESCO Chair of Social Policy in Asia in the Lee Kuan Yew School of Public Policy. He's one of the best-known public policy analysts in the world, and today he's going to present a paper on health policy design, the case of Singapore. As usual, the format is a 30-35 minutes presentation, and then we're going to have a Q&A session. So each of us will have a chance to ask Ramesh a few questions. Ramesh, the floor is yours.
Yeah, hi. Well, I would have normally said glad to see you, but I don't see many people, but glad nevertheless. I really don't need to highlight the importance of healthcare to this audience. You would know, but we should keep in mind that this is there are 100 million people in the world currently, 100 million people who do not have, who are pushed into extreme poverty due to healthcare costs. That's a lot of people. And this is despite the SDG commitment that all United Nations members have made to ensure that all people obtain the health services they need without harming their financial situation. And no one less than Donald Trump admitted, and this is the quote, nobody knew healthcare could be so complicated. At least for once he was right, partially, because a lot of people obviously knew. But a lot of policymakers who claim to know actually don't. They think it's a much simpler problem, as Donald Trump thought. It's really complicated. So people like Kai Hong there in the audience, he would know, and there are many other people, who have a long enough, broad enough exposure to health policy to understand the main challenges. So what I, with my PhD student, Azad Bali, Azad Bali, I keep calling him a student. He's not a student anymore. He's an assistant professor at Australia National University. We do is systematically apply a policy perspective, public policy perspective. Health policy has been studied by health economists, health analysts, all demographers, sociologists, historians, all kinds of people, but there are remarkably few people trained in public policy who study it. And what makes public policy perspective significant is that they treat it as a problem. Lack of access to public policy is a problem, and you apply a problem-solving approach to it. So then the first question becomes, what are the key problems? And again, I didn't invent them. These points are individually very well known. What we try to do here is put them together in one place and then systematically apply it to a range of countries. And by the way, this came out as a Cambridge University Press book only a few weeks ago. So somebody there may want to place an order for their library, much appreciated, if you could. And Cambridge University Press books are usually very reasonably priced, so I don't think that would be a major problem. So why is health policy so difficult? First of all, pervasive information asymmetry and moral hazards. If we have even a bit of an exposure to economics, you would know what these are. In health policy, they have a particularly They are particularly pervasive and have a pernicious effect. The contradictory interests of stakeholders. The patients want free access to everything, the latest, the greatest technology. The providers are very happy to provide them. The insurance companies don't particularly care so long as they can pass the bill to somebody else. The only thing they all agree on it is that supply as much as possible so long as somebody else pays for it. But when it comes to who will pay for it, then it, of course, it becomes difficult. How much to provide? Who should get it? Who should not get it? Question. And the last point, which we underestimate, and especially the public policy people, is the legacy of past policies. Choices made in the past persist. They create their own winners and losers. These winners will not allow changes. So so many of the health policy recommendations ignore the fact. No country in the world starts from a clean sheet of paper that they are given the choice of designing any health policy they wish. Even in a country such as Kazakhstan, where the health system had collapsed and the government did try to replace it with something new, they found out that no, they are really. But in the case of Kazakhstan, which we won't talk much about today, luckily they had some essential features that fit the principles of health policy design very well. So on that count, at least, Kazakhstan does very well. And these challenges are innate to healthcare. They are independent of the country or political system. So whether it's this country or this political system or that political system, they will have all these three major large categories of problems. So overcoming this, so these are the policy problems. These are the problems that we need to solve. And to solve these problems, we need policy tools. But we particularly need tools that match the problems. So what are these? And to understand the tools, we need to conceptualize the functions, the health system functions. So if there is a health system, what functions does it perform? And what are the lapses in those functions that need to be corrected? And what are the most appropriate tools for correcting them? And so here is a better summary. So the functions is the health system functions that we highlight is the first is governance. And the tools are stewardship and coordination. The stewardship here would mean envisioning a goal and coordinating efforts. In healthcare, this is very problematic because of the information asymmetries that we mentioned earlier. Provision. How to provide healthcare? Should it be provided through the public facilities or private facilities? Financing is another function. The tool would be risk pooling. What kind of risk pooling is appropriate? How are providers paid? Should they be paid retrospectively or prospectively? Setting standards for both the products, services, but also the market itself. So, as you can imagine, this is discussed in about 30, 40 pages in the book. Here, I just glossed them in one table. But those of you interested, many of you will actually can intuitively understand if we are exposed to this language, if you have been in health policy, but others may want to have a look at the book. I believe the publisher has made the introduction freely accessible. So what I'll do is I really don't have much time to discuss the case of Singapore, so I'll just talk about these functions and tools and give some examples from Singapore. Of course, the details are available in the book. And what inspired us to write this book was that the healthcare achievements of many countries in Asia are not sufficiently appreciated in the literature. Not just Singapore, which is actually ranked very highly, is well known, but there are other countries in the region, which we look at Thailand in the book. We look at China. China actually is an amazing case for getting it almost entirely wrong. They have now they have got it right, and they are on the right track to fix many of these problems. Hong Kong is an interesting case in a different way. Quite by accident, they had designed the system very well, but now they are tinkering with it without understanding the essential characteristic of the system that they have. South Korean policymakers too, in the last 2 decades or so, have become very savvy, but they are faced with a system that the legacy of the past. So they know what is wrong, but they don't know how to overcome them due to political difficulties. So which one did I miss? Yeah, so that's the 5 countries we look at in the book. Just a quick rundown of how they are doing. Look at all these countries that we cover, China, Hong Kong, India, Korea, Singapore, Thailand, they spend relatively less. The OECD average is around 10%. USA is, of course, the outlier, 17% of GDP. If we exclude USA, then it's about 10%. But all these countries except Korea actually spend half or less. And life expectancy is actually some of the best. We include India mainly to show that how you could get it very wrong, or live in some kind of a fantasy land when you think you are doing something, but you are doing something very different. But in the last 5-6 years, they too have got it, and they're trying to put it back together and correcting some of the systemic. So a life expectancy of India is, of course, a much poorer country than the others listed here. So let's not look at the USA or India, but the others, they have a pretty good record. We earlier mentioned that 100 million people in the world have catastrophic healthcare expenditures. And in China, 20% of the population, that's a very large number. Korea, 21%. And keep in mind that both China and Korea have universal health insurance. So why are 20 and 21% of the population facing catastrophic health expenditures? So obviously there's something wrong. They have not fixed. So we said that we will look at 5 different functions. Let's start with governance. Governance refers to arrangements for organizing collective efforts to achieve goals. And here we mentioned the tools we mentioned was stewardship and coordination. Stewardship includes envisioning goals, setting directions, mobilizing resources, and allocating roles and responsibilities. And coordination involves vertical coordination at various levels of government. Even centralized unitary political systems like China or Indonesia, it's actually healthcare is a very decentralized subject. Of course, in the federal systems, healthcare tends to be, in fact, I don't know of any country where the healthcare is a national subject. It's always regarded as a provincial or a state or a local subject. So coordinating healthcare vertically is very difficult. And healthcare usually involves many agencies. So even small countries like Singapore have many agencies involved in healthcare. In large countries like China, you will see 6 or 7 agencies with major responsibilities, how to coordinate their efforts. In the last 10 years, we noticed that all countries in the region have improved their governance in the sense of providing stewardship and greater coordination. Yet goals remain mostly fuzzy. They're not really clear. Saying making healthcare accessible to all is not really a goal. It's a statement of intention. To spell it out in detail, is much harder, and especially in a political sense. So the countries avoid spelling it out. And without that, as we know in public policy time, unless the goals and objectives are clear, it's hard to make a policy. Implementation has improved, but again, there are challenges which we list in the book. Singapore, sometimes I throw Singapore and Thailand together, but we'll focus only on Singapore today. Singapore is amazingly clear in its objective. Sometimes when some of the particular actions don't make sense, why is the government doing this? It doesn't really make sense until you realize what their objective is. Making healthcare accessible to all is not the only objective. They are very clear about the goal of individual responsibility. So quite often, some of the policies, for better or worse, and sometimes it is for the worse, this goal of making individual responsibility comes in the way, or at least makes it difficult to achieve the other objective, is to make healthcare accessible to all at an affordable cost. Vertical coordination in Singapore is not a problem. There's only one level of government. But in other countries, it's a major challenge, and they overcome it in different ways. Here, just as an aside, I can mention that while talks of decentralization, local autonomy all sound very good to the ears, in healthcare, they're very difficult to achieve. In fact, all the better performing healthcare systems are quite centralized. So if you take in the case of Europe, the better healthcare systems would be Italy, Spain, both very centralized healthcare systems. And in the region, again, it would be Thailand, Singapore, Hong Kong, and they again very centralized systems. And it's not about centralization or decentralization. The key idea there is to the right type of decentralization. What are the functions? Instead of following it as a general ideology or a belief system, decentralize things that can be meaningfully decentralized, things that cannot be run from center. What are the functions that are best performed from the center, and what are the functions that are best performed at the local level? To have a clear idea and sort them out accordingly is the real challenge. Oh, sorry, I moved ahead a little bit too much. Ministry of Health in Singapore is quite a very senior agency. It's one of the most respected ministers. One of the senior most ministers is usually assigned to health. Unlike many countries, I'm thinking of India or even China, where fairly junior ministers are allocated to healthcare. It doesn't have in Singapore, say, give another example, would be education. Education usually in most countries is assigned to a fairly junior minister. In Singapore, one of the senior most ministers will be handling education and healthcare. And Singapore has a unique governance structure, and I don't think any other country in the world has it, that they have a private company, and and what's the word? Private company called Ministry of Health Holdings. As you can imagine, there's a contradiction here. There's an oxymoron here. It's a Ministry of Health, which means that it's the government agency. Ministry of Health Holdings Private Limited is the complete name. So what makes it private? Well, it's private in the sense that it's registered under the Companies Act. But the company is entirely owned by the government. Why would you do that? It's actually very clever. It allows the government to oblige the company to be autonomous. And yet, as the owner, exercises ownership right, just as shareholders or owners of a company can direct the company management to do whatever its goals are, the government can, but however, in operational matters, the managers of this company. So what does this company do? It owns all the assets of the public health system. So all the government hospitals, government clinics, lands, buildings, equipment is owned. And so as an owner, it can allocate resources. It can set out the strategic objectives and yet leave it to the managers to run the everyday operation. It's quite an innovative institutional arrangement that I haven't, there is insufficiently captured. And again, the tools are, it's a really good idea, example of tools thinking, that you set up a goal and you try to figure out the figure out the tools that are most appropriate. Unlike other countries where you may think, oh, marketization is good, state ownership is bad, it's none of that over here. So what aspect of the public ownership is good and useful, and what aspects of private ownership is useful, and you try to combine the two through this vehicle called Ministry of Health Holdings. So now let's look at the second function, is a provision. So basically it involves organizing the public and private providers in a configuration that leads them to serve the government's goals. And here the objective needs to be that they work in the public interest and not their own interest. And for private providers, this usually means curbing opportunities for profit maximization at the expense of users. And for public providers, it involves motivating personnel to remain responsive to patients' needs and pay more attention to management issues. So most countries will have both private and public providers, and you need tools, different tools for them, because the nature of the problem in both is different. So a same tool will not work for both. So private providers, how to, while allowing them to enjoy autonomy, compete in the market, be responsive, how to curtail their innate urge, and actually not just innate, it's expected of them under the private, under the corporate expectation. And for public providers, they are civil servants. If you put them on a civil servant terms, then they may or may not pay attention. How to motivate them, how to take management tasks more seriously. And it doesn't help, as in the case of actually Singapore too, to some extent, but in India particularly, well, the managers keep getting transferred. So no real health policy. You may be running forestry today, finance next year, and health third year, and they know that they're going to be there only for a year. Why bother? And the hospital management is in the hands of the senior most surgeon. So you take your senior most and the best surgeon and put her or him in charge of management, about which she or he may know nothing. So, all hospital managers in India and many other countries tend to be the best doctors. So you really are losing out on both fronts. You have lost a very good surgeon, and you have gained possibly a very bad manager. It reminds you of university sometimes, but that's a separate paper. And what government ownership does, it allows direct intervention through internal instructions. Instead of negotiating with external parties, as would be the case if they were private, you can just instruct them. So like hospitals in Thailand, Hong Kong, Singapore, most of them tend to be owned by the government, which means that they don't need to be regulated. You can just instruct them directly, which is much quicker and much more flexible, provided you know what you're doing, of course. Of course, they have other problems, that they're bureaucratic structures and processes, how to overcome them. And some of the better ones are like Hong Kong, Singapore, Thailand again, where you have to pay them well, you have to reasonably well. In many public systems, they just pay too poorly to remain motivated. They are looking for an opportunity to just leave the public sector if they could. In Singapore, 80% of the hospital beds are in private sector, in public sector, which makes it quite easy to manage for the government. And the next feature of the Singapore system, and again, this is perhaps unique, is that each hospital is an independent corporate entity, but again, fully owned by the government via Ministry of Health Holdings. So each hospital will have its own board of governors, governance structures. So it allows the government to combine both the public and the private sector features. The managers tend to come from both private hospitals as well as public hospitals. Many of them are actually civil servants with quite a bit of exposure in Ministry of Health as well as other ministries. And it makes for an interesting management. Government, of course, has a direct access to management control over them through ownership rights, in addition to regulatory rights. How am I doing with time? I'm already almost. Anyway, I'll speed up from here on a little bit. Actually, I'm not going too badly. So managing risk pools. Of course, I know you could be private or public, and if it's public, then it could be social insurance or government budget, and so on. Different pools offer different uses. Insurance is, of course, the social public insurance is a very popularly and widely used tools. It's a politically a very easy tool to adopt. It's politically easy because you collect premium and pay. It shouldn't cost the government budget any money. Providers, doctors love it because somebody else is paying for it. Actually, even the insurer loves it because they don't have to do anything. They just pay. The problem arises when the demand becomes so high that the premium need to be raised. And of course, insurer, as much as they may like, government doesn't like it, population doesn't like it. So initially, social insurance is a very government budget is somewhat easier on that count because it's a government's budget. It can allocate it. The problem, of course, is that it has to compete with the other budgets. Advantage of a government budget as a risk pooling sources, that government can attach conditions to the transfer. Insurance companies can do it too, but why would they? Because it's not really their mandate to improve the entire healthcare system. So in Singapore, government actually sets very detailed condition. So when a public hospital receives money from a government, they sign a contract. So remember, the government already owns these hospitals. On top of the ownership, as you see soon, they regulate it. But in addition to regulation, when the government provides them with financing, very strict conditions are attached to it. And China found this out in the 1990s. When you reduce the government transfers, you lose a leverage. And in Singapore, government finance is not the majority source. However, it's large enough for the hospitals not to take it lightly. They would like to continue to receive the money. And to receive the money, they must abide by the conditions. And this is a tremendous leverage that the government has in shaping, particularly the private hospitals. Well, this one, we're running out of time. A government of Singapore, and especially casual commentators, make a big deal out of one of its financing sources called MediSave. MediSave is the scheme where you are required to save for your healthcare treatments, that involves significant expenses. It forms a very small, I think it's overdone it. It really plays a fairly small role in the total health system. However, if we remember the initial goal that I mentioned, that everybody must accept individual responsibility for healthcare, then this MediSave makes a lot of sense, because it's your money in your account. It may form a very small role in the overall role, but it's actually a very major, I personally think it's an ideological role. But another one is out-of-pocket payment. Unlike many other countries where the government is committed to paying for the entire healthcare and inadvertently finds that there is a significant out-of-pocket payment. In Singapore, it's an explicit goal that everybody must pay some part of the healthcare expenses. So the tools actually match the objective. How providers are paid is a major issue in healthcare, and when we shop at a department store or a grocery store, it really doesn't, it's all as you pay as you go, in the sense that you pay for what the services you receive in a haircutting salon or a shirt that you buy. In healthcare, that's not a very good idea, because the provider has an almost infinite opportunity to provide you with services. And as a consumer, if somebody else is paying for it, you really don't have any incentive to stop them. So how to, one way to do it is to offer a fixed amount of money. So $1,000 per person transfer. So they have to manage the entire healthcare needs of a person. This is, of course, is fabulous, because you know your maximum expenditure, $1,000 a person. The problem there is undersupply. The provider now has an incentive to give you a lot less than $1,000 worth of services. So it requires a fairly deft government to write contracts, to monitor the contracts, so that hospitals are not, or providers are not under-providing. So all countries in the all around the world, or many countries in Asia, are trying to move to this prospective systems, but they have a tremendous difficulty in making it work. In Singapore, it's a small country with a capable bureaucracy. They've been doing. They have a combination of finance payment tools, increasingly in the form of cap payments. So the last one is regulations or standards setting, ensuring safety and quality of medications, treatment, and services required. They are particularly important when providers and third-party pays private entities who have an interest in maximizing profit. So regulations are much more important in systems that are dominated by private providers. And so unsurprisingly, Singapore, since vast majority of the hospital providers are in the public sector, it has relatively less need for regulation. Unlike, say, Korea or India, or Philippines, where vast majority of the providers are private, those countries require very strict regulatory regime for the health system to function and meet its goal. In the case of Hong Kong, Thailand, Singapore, vast majority are public. So it's unsurprising that they are not. And Singapore, of course, also has an additional objective, and they are very is to attract foreign patients. The advantage is not as much as it used to be, but many patients in Indonesia, Malaysia, Burma, they prefer to come to Singapore, and Singapore would like that. If you control them too much through regulations, it stops them from their marketing activities, and and since they are not your citizens, you don't particularly care, so long as there's some broader limit. So the regulatory regime in Singapore is fairly light, and quite understandably so. So many of the health policy literature that talks about regulation misses the point that it really matters whether your system is dominated by private or public company. So as you can imagine, I glossed over most things. What is discussed in a few hundred pages, I just tried to very badly summarize in more than half an hour. Okay, I'll stop here, Ricardo. Sorry, I can. I'll try to explain. I do a better job in my explaining it if there are questions.
Thank you, Ramesh. It was very interesting, and I think that you raised several points that I'm sure our participants would like to dig deeper into. So the floor is open.
May I ask a question?
Sure.
But actually, it may be sound not very smart question. I'm not from the public policy area, but I'm wondering, it's a very interesting case how Singapore combines this. So a private firm fully owned by the government, and this structure, is it specific only for healthcare in Singapore, or the same structure is used in some other areas? Because I'm not very well aware about the policy, the public policy in Singapore, or it is only for the specifically for healthcare.
Actually, there are a lot of some of the world's largest companies are based in Singapore, and these companies are actually they're called private company, but they are fully or partially owned by the government, but they're called private companies. Actually, at Nazarbayev University, I taught a course on public enterprises, and students found it very interesting that you actually have private companies owned by the government. So are they public or private companies? And China learned from Singapore, and China too has a lot of so-called private companies listed on the stock market with the majority stock shares. What is unique about health is that it's 100% owned. It's a not listed company. Usually they tend to be listed company, they're public company. This is a private company. It's actually private limited is in the name of the company, even though it's 100% owned by the government. But the governments are sovereign, they can own anything they buy and do what they want. So if you call a company a private company, it's a private company. And actually, it's more than the words. And they are they're guided by the company charter, where making money, or at least not losing money, is an expectation, is a prescription of the charter. You must recover the cost at the very minimum. So a hospital cannot lose money.
Thank you, Ramesh. Gulala?
Thank you, Professor Ramesh. I have a question about Singapore has some challenges in the healthcare system, like from public to private in both sections. So my question is, like, can foreign patients, for example, get beneficial health services, for example, in the terms of financially and both quality of the health service in comparison with South Korea or Japan or India, for example? Thank you.
I understood most of the part of the questions, but there was probably something I didn't, because can you repeat the question again, please? So what was the specific question about Singapore?
The specific question is like, is the quality and quality and in the terms of financial services? I mean, in the terms of quality of the health services they get in Singapore, and is there like a big is there a big change in them? For example, comparing both countries, South Korea and Singapore. Like
So
for the foreign patients, I mean.
Oh, for foreign patients. Okay, so this is the important one. So if you are a consumer and you have a choice between Korea and Singapore, then where would you expect? I personally don't know, and because patients value things that are not very important from a health systems perspective. Patients can only observe what they see. So for them, the garden around the hospital is very important. The lobby is very important. The cleanliness is the toilets. From the health system perspective, none of this is important. Some of the best healthcare systems are those where the hospital tells you that you will not be given this service. And in fact, that is the biggest challenge, that the healthcare service providers are very keen to provide you with, to make you happy. And making a patient happy in this general sense of being given whatever they ask for is a very poor from the health system perspective. So when you say service is good, if you're looking from I would imagine that the one in Korea, because most of them would be private, if they would be very good, because otherwise they won't stay in business. But the private hospitals in Singapore will be, would be similar. They also will do their best to attract customers if they have the ability to pay or have some insurance that pays for it. But going to the essence of the question, quality as in pleasing the consumer, but otherwise in the terms of clinical quality, I don't know whether which one is better. Clinical quality is notoriously difficult to compare, and across jurisdictions, it'll be nearly impossible to compare. But I'm sure somebody may have done the study, and if you are familiar with it, let me know.
Thank you, Professor.
Aziza.
Thank you, Dr. Ramesh, for presentation. I want to ask about the financing the healthcare system. You talk about two types of risk pool, and could you tell me which type of risk pools are fairer and more equitable for healthcare system?
On that, we have plenty of evidence over going 40-50 years. Publicly financed systems are the most equitable. And some of the best performing the healthcare systems, especially in terms of efficiency, are the public systems, the Italian system, the Spanish, Singaporean, Hong Kong, Thailand, all these countries are publicly financed. I added another layer of argument to it. It's not just the public financing part of it, but governments can do more than just transfer money. They can write conditions, which Singapore government does very, very well. Other countries also do it. All countries lay some conditions, but you can design those government financing in a great deal of detail to achieve the objectives you want to achieve. Yeah, but as a general principle, public financing, and that way Kazakhstan actually does very well too.
Yes, thank you, Farhan.
Yeah. Hello, everybody. Thank you, Professor, for your information, for your insights. My question is also about the healthcare financing. I think it's important because Singapore managed to make good outcomes at 4% of GDP. So question is how it's exactly organized. You mentioned, before you mentioned that the structure is like you have a private and public and private insurers, if I saw it right. So how it's organized? Do you have one huge public insurance fund who is a payer, or you have several funds, including private funds? So how structure work?
Let me first say that Singapore does not have a insurance financing as the main source of healthcare finance. It has many sources of equal. In fact, it's currently the government is the largest. Government budget is the largest source of financing. Insurance financing is actually very, very small. The second largest source is out of pocket. So insurance, and this is not by accident. It's a deliberate choice. The government of Singapore is very aware of the moral hazard problem. When somebody else is paying for your care, both the providers and the user does not have incentive to curb it because somebody else is paying for it. So it's as a deliberate policy choice. However, at the same time, the government has become increasingly aware that it's not possible for people to pay out of pocket for all the services, even a small percentage, because their income may not be high enough, or some of the modern diseases are so expensive to treat that some sort of insurance financing is unavoidable. So government has this MediShield scheme, which is a treatment of critical illnesses, so stroke, heart attack, all those major treatments. For that, there is any public insurance. But here politics comes in. Middle class everywhere in the world does not like public hospitals, because public hospitals tell you that you will not be given. So if you go for a flu, public hospital hopefully will tell you that there is no cure for flu, go home, sleep. Custom users hate that kind of facility, which tells you that you won't get what you asked for. But you can't ignore it, right? Middle class, upper class doesn't care. They can pay out of pocket. Poor people are very happy to get what they get. But in a society with a very large middle class is a problem. They want everything, but pay for nothing. And they would like or pay very little. So government of Singapore also can't resist that pressure. So private insurance is available. But these private insurance premiums were going up so much because once you have bought a insurance, right? A Cadillac, or what they call Cadillac insurance. In Singapore, it will be called a Rolls-Royce insurance. You show up at the hospital and you ask for everything that they have, because you have paid a lot of money for your insurance. So the government has actually introduced a regulation 3 years ago that no insurance can cover 100%. You must pay out of pocket. So if you go for $100,000 treatment, you will be required to pay at least 10,000. So hopefully you will pause. And this is in addition to the premium you've already paid. So the government is very aware of the, and have been aware for the last 40, 50 years, because setting up an insurance is very easy, right? All countries can do it. As you know, nothing is easier than setting up a social insurance. The problem is how to stop them from not supervising the system. Only some countries have done a good job at it, using a social health insurance. Japan is supposed to be one of the better ones, where it's an insurance finance system, but still manages to keep its cost down while providing a reasonably good quality service. But in Singapore, the government has done its best to avoid it.
Okay, and one more detail. Who's exactly the payer on the government side? Is it the Ministry of Health or like a special entity? Oh, directly. Okay.
Yeah. It transfers money directly to hospitals. And remember, these hospitals are private companies. So they have to write a contract as to what they will do in return for the money. And government can, since it's giving the money, it can supervise them very, very closely, as any owner would. It's a contractual obligation. It's not an automatic transfer that you get the money because that's what. Well, I know you have some entitlement to it.
Okay, got it. Thank you.
Makpal, you have the final question.
Hello, thank you, Dr. Ramesh, for your presentation. I would like to ask, you mentioned that some of your information came from your work, health policy in Asia. And may I ask you about the methods were used while performing this research?
Method? You mean how I collected information?
Yeah, thank you.
They are all mostly these days available on the websites. The information. But I've also been working on these topics for 15, 20 years. So, but in fact, in healthcare, the usual problem is what to do with all the information that is available. There's so much information available, sorting through the information, and the way many of the researchers respond is to take a very small slice of it, the information. And there's a shortage of people who can have an overview of connecting the various information and analyze it in a policy relevant way.
Okay, thank you very much.
So this is the final question. Go ahead.
Yes, thank you very much. Thank you very much for the presentation. I have a question. As we know that one of the major source of income in private hospitals in Singapore is medical tourism. And now after the pandemic, during the pandemic and restriction with all borders, how do you think did it affect on the quality of health service provision, or it did not? Is there any difference in terms of health delivery in private hospitals? And the second question, you mentioned that is coming information from the book. Is the book available? Would it be possible to read, to find the book? Thank you.
To answer your second question first, yes, the book is definitely available. I haven't tried to buy it, but yeah, I did see it on the website, Cambridge University Press website. So if you have difficulty accessing it, just ask the library to acquire it, and then you can read it. But if you want to buy it, please feel free. Yeah, but it's definitely available now. And to go to the first question, keep in public and private hospitals. Government hospitals form more than 80% of all beds. So only 20% of the beds are in private hospital. So it's a public system that drives the entire health system, not the other way around. So secondly, of course, there's no tourism going on, healthcare tourism, but the government has no obligation to protect the profits of the private hospital, right? It has no obligation whatsoever. I haven't seen, these are private companies. They obviously would have limits in what they how much information they provide. I would imagine that they are losing money, but they also provide a lot of Singaporeans too prefer private hospitals for cost they can have a reasonable idea. So for childbirths, private hospitals are extensively used for status purposes mainly, and I don't think that has been affected by the pandemic very much. Yeah, but the short answer is, from the health system perspective, it doesn't make much difference. Of course, you're an investor in a private hospital. If you own a private hospital, then it probably has made a big difference to your profit margin.
Thank you.
Thank you, Ramesh, for the presentation, for joining us after such a long time. It was a pleasure to see you, and it was very interesting to listen to you. And we'll make sure we order a couple of copies of your book for our students and for the library. So thank you so much for joining us and for giving us a presentation and for discussing and taking so many questions from the audience. It was a pleasure to have you. And thanks everybody for joining us, and we'll be here again for another webinar soon. Thank you very much.
Thanks so much, everyone. I enjoyed the chance to connect again, and may better times return.